Hello, everybody. Welcome to our webinar today. We'll be starting in about 2 minutes. This is the third of the WHO reINVENT webinars from evidence to policy. Just a quick reminder of a few housekeeping points before we, as I said, before we begin. This webinar is being recorded, so that's important to know. Please do keep your mics muted. We'll be using a Q&A function throughout the 90 minutes of the webinar. So we will not be looking at your comments in the chat at all, only in the Q&A. And we'll try and weave in your questions on the Q&A so that our panelists can actually talk to them, answer them, be provoked and challenged by them. We'll do that as much as we can. We've got a lot going on today. We've also asked the WHO team and the panelists to also respond on the Q&A itself if they get a chance to do that. So please do remember, do use the Q&A, don't use the chat. And as I said, we'll be starting in just about a minute. So if you think you're here for the WHO reINVENT webinar, you're in the right place. If you thought you were here for a different webinar, go somewhere else. No, that's we'd love you to stay with us anyway. I am going to start a little bit more formally right now. So good morning, good afternoon, good evening. My name is Amanda Harding. I need convene, and it's really my honor to be moderating this third reINVENT Rebuild webinar. From evidence to policy, physical activity and COVID-19. We have a really short 90 minutes to cover a hugely rich agenda. We have with us the world's top specialists, and with them we will expose, discuss and propose ways forward. The first part of the webinar will take a look at what the latest science is telling us on physical activity and COVID, with a specific look at the preventative benefits of physical activity from severe COVID outcomes. We will go on to talk about the implications of these findings on public health, policy and practice, and the enablers needed to see behavior change really happen. With attention still to the science and the science policy science practice interfaces, we will interrogate the priority research studies needed, the investment challenge and capacity to meet these ambitions. As for our panelists today, we have with us Pedro Hanna from the Federal University of Pelotas in Brazil. We have got a few people who is a really early start to the day. I'm just realizing this as I'm going through the list. Bente Klalund Pedersen from the University of Copenhagen on the same time frame as me. Hi, Bente. Jim Salas from the University of California, San Diego. Bob Salas from Kaiser Permanente Medical Center in California. So to set the scene for today's webinar, that was a very quick run through. You'll get to meet everybody over the 90 minutes. But to set the scene, I'd like to turn over and welcome Fiona Bull, who is the unit head of physical activity for WHO. And she really is the driver of this webinar series. So Fiona, over to you.
Well, thank you very much, Amanda, and a very good morning, early morning for some, good afternoon and good evening. Welcome to you all joining this third reINVENT webinar, a series of 8 webinars, which we're calling reINVENT as we are challenged by the COVID pandemic and have the opportunity to use the COVID pandemic as a way to look at our work and our agenda and our shared goal of creating a more active society and benefiting from physical activity for health and social outcomes. I'd like to extend a very warm welcome to WHO colleagues from headquarters and the regions and countries, a warm welcome to health professionals across exercise, fitness, physical activity and sport, and of course to all the scientists and academics joining today for this particular forum that focuses on the science. The origins of this reINVENT series are from April 6th, the International Day of Sport for Development and Peace. a day where we celebrated the role of sport and physical activity, but we also reflected, and we reflected on the impact of COVID on us individually, but also on the system, on our work, whether that's research and of course, those of us in the industry and the sector of providing programs to communities. It's been hard, and it's now been a long time. To contribute to the reflection and learning from this experience, WHO held a webinar on April 6th, and this series is an extension of the conversation about how we can adapt our system and our work because of COVID, but also how we can learn from it and identify what we can do to build forward a stronger, fairer, more inclusive system. And as we do look forward, albeit from different vantage points, different contexts, different parts of the world and different situations, we must learn from this. And so this series is very much a dialogue, a conversation with you, the audience, and our panelists to hear how we can have practical actions and policy responses to build forward better. The purpose of the reINVENT is to raise issues, and we have in our first 2 weeks looked at the sport and exercise sector, and today we're putting the spotlight on the science of physical activity and health, and critically the science of physical activity relating to COVID-19 and its outcomes. It's well known and reaffirmed in WHO's recent guidelines published in November that physical activity benefits and offers protective effects on the leading causes of disease, the chronic diseases such as coronary heart disease, diabetes, hypertension, of course, cancers. And these have been brought to the fore during COVID, often referred to in that phrase, underlying conditions. And so we are today going to, with our panelists, be looking at the science that's come out, recently published across the year and in recent months, to identify the role physical activity can have now and going forward, what the science says, what we understand about it, and what it should, how it should be used to inform policy and practice. The webinar series is a process and a product. The process is what we're in today, the discussions, the questions you'll be invited to pose, and the panelists' discussion amongst themselves. And it's a product because WHO and the UN system is listening, recording and listening to hear what are the practical actions we can take forward and recommend to countries responding now in the response phase to COVID, but going forward in recovery plans, policies, and investments. WHO will produce a report, and we will announce that report in our final 8th webinar planned for September. And so with this introduction, I offer a very warm welcome to everyone again, and we're very pleased to start the session by going into looking at the science. And it's my great pleasure to introduce our first panelist, who is from WHO's Office of the Chief Scientist, a new office reflecting, of course, the role and importance of science here at WHO as the UN technical agency. And we're very pleased to be joined by Dr. Soumya Swaminathan, who is the Chief Scientist. She was unable at last moment to come personally, but made a video of her introductory remarks to us. So thank you, Wana. Let's hear from Soumya.
Greetings, I'm Dr. Soumya Swaminathan, and it gives me great pleasure to say a few words to you at this third webinar of the reINVENT series, where you're looking at physical activity and COVID-19. I know that you're looking at the evidence on the mechanisms whereby physical activity affects the immune system, reduces inflammation, looking at the association of physical activity and the severity of COVID outcomes, and also the emerging evidence on long COVID and the role of physical activity in the rehabilitation of patients. I'm coming from the science division. I had the science division of the WHO, newly created about 2 years ago, and we've been working very closely with our colleagues in the emergencies department, but also in other departments across the organization in order to ensure that our normative guidance and our policy making is driven by the best available science and evidence, that we follow the right processes and the methods to collect that evidence and review it and synthesize it, and that our guidance is produced in a way in which it's easily adaptable and implementable at the country level, and that it makes sense to our end users. So this is a journey that we're on, and hopefully we're going to keep improving the system and getting better at it. Obviously, COVID has challenged the world, challenged all of us, highlighted the gaps in our knowledge, both at the level of basic science, understanding of the pathogen, in areas of public health response, social and behavioral sciences. We set up a new group, the Behavioral Insights Group, that also came with what you need in terms of insights for successful behavior change, and learning to not only understand and keep up with the science, but also how to communicate this to the public as well as to the policymakers, so that the policy health responses that are needed to protect people, particularly those hard-hit communities, that communication and the response has been challenging, and we've seen a huge impact on not only lives but livelihoods all over the world. It's important also to note that most countries followed the precautionary principle, and this included closing of spaces which could involve higher risks of transmission, where people gather, and these included parks and beaches and gyms and sports facilities and sports events. And these were very hard on people, but were obviously necessary at the times that they were done. It became clear quite early on in this pandemic that people who had underlying chronic diseases were disproportionately affected by COVID. They were at higher risk of getting severely ill and of getting hospitalized. And this again has brought the attention back on the non-communicable diseases. And WHO, of course, has long advocated for strengthening of NCD services and management, but also prevention to continue. And the COVID brought back the need and focused on the unmet gap for prevention and treatment of these diseases. And this is tobacco, this is hypertension, it's obesity. All of these have been highlighted by the WHO. We've also worked closely with the sports sector, and the DG has been very proactive in reaching out to the different sports associations, both to support the development and adaptation of the risk assessment tools and risk assessment guidance and measures, to help sports bodies to respond to both in terms of safe procedures to be followed, to reopen safely when the time is right, but also to encourage people to continue physical activity and sports wherever and in whatever manner was possible. So going forward, I think we all need to capitalize on this wake-up call that the pandemic has provided to us to ensure that NCD prevention and promotion of good practices such as physical activity or addressing the risk factor of physical inactivity needs to be front and center in national response and recovery agenda. We know that this is a problem across the world, more so in some countries than in others, but we know that obesity and physical inactivity are significant risk factors, and that the pandemic could only have exacerbated it and made it worse. So the science division that I represent really welcomes this webinar, which is focused on research on physical activity, to hear about and discuss the research evidence on the impact of physical activity on health, particularly as it relates to COVID outcomes, and also to identify and prioritize a research agenda for the future, because again, that's one of our roles, is really to identify the gaps in knowledge and to prioritize research questions that could be addressed by the research community as a whole, but also by research funders in different parts of the world. And we have recently developed a stronger and a clearer process for a very systematic and transparent research prioritization methodology, and we are working with our colleagues in different departments in the House to see how they could really use that. So I'm very glad to see that this is happening, and look forward to your identifying the priority research questions so that we can help shape the global research agenda in relation to the role of physical activity in infectious diseases such as COVID, and how to scale public health action to promote physical activity in COVID recovery plans, and more widely, our long-term global health agenda to successfully increase physical activity and achieve the agreed global target for 15% improvement or increase in physical activity by 2030. So I wish you a very good discussion this afternoon, and look forward to your outcome document and ongoing collaboration with all of you. Thank you very much.
Thank you very much to Dr. Soumya from the Chief Scientist's Office. Very important messages being shared from the office, reminding us how important WHO takes the science and to put it into the norms, standards, guidelines. And as I heard very clearly, a call for us to start shaping and contributing to shaping the global research agenda. So to panelists and audience, if you only had 5 research questions, what would they be? Because we cannot have a research agenda that's got hundreds. So through the next 90 minutes or so, tell us what you think are the most important research questions, and listen to what our panelists think they are too. And it's my great pleasure to start the panel discussions and presentations by introducing again Dr. Bob Salas. Good afternoon, well, very good morning to you, Bob. Family medicine physician practicing at Kaiser Permanente in California, director of the Sports Medicine Fellowship Program there, past president of the American College of Sports Medicine, chair of Exercises Medicine Initiative, healthcare leader in the Physical Activity Plan of the USA. We are delighted to have your contribution, particularly because of the latest work you've done. You've put into the published scientific forum the science on and evidence from a recent study. And I'm delighted that there was so much media coverage, which I think reflects the interest. And so I'd like to hand the floor to you, Bob, to use your slides, and over the next 5 or so minutes, take us through the headlines of that study and the results. Over to you, Bob.
Thank you, Fiona, for that kind introduction. And it's really a pleasure to be here today to present the results of our recent study. Certainly, I think we all have great evidence on the potential benefits of physical activity with regards to COVID. Studies suggest that doing regular moderate to vigorous exercise can improve immune function. It can reduce systemic inflammation, and certainly we know it benefits cardiovascular health, lung capacity, muscle strength, and mental health, among various other benefits. We also know that regular physical activity has been shown over the years in multiple studies to reduce both the incidence and severity of virtually every chronic disease that has been known to increase the risk for severe COVID-19 outcomes. And so this led us to compare the risk for severe COVID-19, which the CDC defines as being hospitalized, admitted to the intensive care unit, and dying. We wanted to compare the risk among patients who were consistently inactive or sedentary, those who were doing just perhaps some activity but less than the physical activity guidelines, and those who were consistently meeting the physical activity guidelines. So at Kaiser Permanente in Southern California, where I practiced my entire career, we use something we call a physical activity guideline, physical exercise vital sign, where every patient is asked on average, how many days a week do you engage in moderate to vigorous physical activity like a brisk walk? And then the follow-on question is, on average, how many minutes do you exercise at this level? And the electronic medical record multiplies those two responses together to give minutes per week of self-reported exercise. And we have validated these questions over the years. We've been doing this since 2009, and we certainly know that it correlates with virtually every chronic disease, how well these chronic diseases are controlled. And so we feel it's a pretty accurate measure of self-reported physical activity. So with this most recent study, we looked at our patients who had a COVID diagnosis over the previous 9 months, the first 9 months of the pandemic. And at that time, we had a little over 103,000 patients in our system who had been diagnosed with COVID. And then we whittled those down to those who had been continuously enrolled in our system for over 6 months and were over 18 years of age. And then finally, a cohort that had at least 3 exercise vital signs in the previous 2 years leading up to the pandemic. We then broke them into 3 different groups: those who were consistently inactive, and by definition, they had 3 or more vital signs, which suggested they were doing less than 10 minutes a week of physical activity. Those who were doing just some activity, they were doing a little bit, but not meeting guidelines, less than 149 minutes. 149 minutes a week or less, and then those who were consistently meeting the physical activity guidelines. And you can see we had over 48,000 patients in our cohort. And you can see right off the top, as we broke those patients down, those who were meeting the physical activity guidelines were about 70% less likely to be hospitalized and about 80% less likely to die from COVID if they were meeting the US physical activity guidelines. Well, we then controlled for all of the risk factors for severe COVID as listed by the CDC, and you can see those shown on the slide here. And we did a multivariate logistic regression, and you can see right away the effect on hospitalization. Those who were meeting the physical activity, doing regular physical activity, were 2.26 times less likely to be admitted to the hospital. And when you compare this to other risk factors, the only risk factors that trumped being physically inactive in terms of hospitalization were age over 60 and a history of organ transplant. And you can also see when we compared those who were doing some activity to those who were inactive, they were 1.26 times, 1.2 times less likely to be admitted to the hospital. So it showed that even doing a little bit of physical activity had some benefit. And then if you compare the odds ratios for death in a similar fashion, you can see, again, the risk of being inactive. If you were inactive, it increased your risk of dying from COVID to almost 2.5 times. And again, it was only surpassed by age over 60, and again, a history of an organ transplant. And you can see here that doing just some activity also gave a protective benefit. You were 1.32 times less likely when compared to being inactive. So the results of our study, to me, really show that how important exercise is in preventing severe COVID outcomes. And I believe this should be an integral part of our prevention strategies. Along with, masking and distancing, we really should be talking a lot about being physically active as a way to prevent severe COVID. And we just don't see this in the national discussions. So I'm happy to take any questions.
Thank you very much, Bob. And we'll just pause here perhaps before we move on to our next speaker, because this is a very important study you and your colleagues have done. And you've introduced the results there. For those not so familiar with odds ratios, we're really looking at the likelihood. And Bob, is it right then? It's almost you're double the risk. You were reporting their odds ratios of getting to around about 2. So, I mean, it seems physical inactivity or the active benefits of activity are substantial. Does this add to a body of knowledge that we knew already, or is this the first study to show us these results?
We've had a variety of other studies that have duplicated our results. And actually, we had a study on our Kaiser Permanente patients using the same vital sign in Georgia. It wasn't done exactly as we did ours, but they also backed up the results that we got. And a variety of other studies around the world, not done in exactly the same fashion, have suggested the same.
Okay. And are there studies outside of the US in other populations? And can we generalize from your study and the one of Georgia?
Yeah, there's a study from the UK Biobank that sort of reflected the same activity, and actually another study that showed walking pace was correlated with the risk of severe COVID outcomes. So this certainly isn't the first study to give us this message. And I think our study, though, is very well done because it's taken right from our electronic medical record. And so all of our endpoints, I think, are very solid because it comes right from the electronic medical record.
Yeah, I heard you talk about this idea of a standard measure and that you have it as a vital sign, physical activity measurement as a vital sign. And we're going to come back to you when we talk about the implications of that. So
Yes.
A study with profound results for us. Your message is that we should therefore be promoting physical activity. What we need to do is to understand a little bit about, well, how and why. So I'm going to pause my questions with you, Bob, but we will come back to introduce our next speaker. And it's my great pleasure to introduce Professor Bente Karlen-Pedersen, Director of the Center for Physical Activity Research, Chief Physician at Copenhagen University Research, medical doctor, specializing in infectious disease and internal medicine. And your career has been focused on exercise and the immune system. And thank you very much for joining us for this global webinar on this topic. Can I ask you, Bente, could you help myself and the audience explain what might be going on? What are the physiological, biochemical mechanisms and pathways that explain the relationship we've just seen? Bente, welcome, and I hand you the floor.
Thank you very much, Fiona, and it's a great pleasure to be part of this. And congratulations, Bob Sallis, with your latest article. We have all read it in our center, and we are just thrilled about it. I even wrote about it in the newspaper before because I think it's such an important message. So I think we all know that severe COVID-19 infection, as we can see to the right here, is associated with a storm of inflammation in the lungs. And now we know that physical inactivity is a risk factor. I should be able to click, yeah. We also know that severe COVID-19 infection is, as Bob just told us, is especially seen in individuals with chronic inflammation, like obesity, diabetes, and other chronic diseases. When you have an infection, it's of course important to create an inflammatory response, but it is equally important to downregulate your inflammation. We are talking about inflammation as a double-edged sword. And what we know is that patients with chronic inflammation, they have an impaired ability to mount an anti-inflammatory response following an acute infection and an acute inflammation. This is what you can see down here. In healthy individuals, after a little time after the infection, then the inflammatory response will be downregulated and the anti-inflammatory response will dominate. In individuals with chronic inflammation, we don't see this anti-inflammatory response. So the inflammation, the pro-inflammatory response will continue and create this storm of inflammation. I just want to tell you how fast it can go when you change your lifestyle from being active to being inactive. This is a study we did some years ago in healthy subjects. We just asked them to be lazy, and they declined their daily number of steps from 10,000 steps per day to 1,500 steps per day for 14 days. What happens here? Right. So they were just lazy. And what we saw was that their ability to oxidize fat was decreased. And what we also saw was that the visceral fat increased. So actually they lost muscle mass, but they accumulated visceral fat. And we know from many pieces of information that this visceral fat becomes inflamed and is a source of chronic inflammation. So what regular physical activity can do is two things. With acute exercise, each time you run or take your bicycle, with each part of exercise, the muscle will create myokines, which will create an anti-inflammatory response. So TNF will be downregulated and the classical anti-inflammatory cytokines will be upregulated. With training adaptation, the results of long-term adaptation will be that you reduce the amount of visceral fat independent of body mass index, independent of body weight. You reduce the visceral fat, and thereby you will reduce inflammation. So I think this idea that exercise creates an anti-inflammatory environment and lower chronic inflammation can at least partly explain the findings by Bob Salis. I think that was my little contribution here.
Thank you, Bente. A lot of science and knowledge there put into just a few moments, and clearly that evidence you shared also shows us the detrimental effects of the sedentary behaviours. One in which, of course, we're experiencing through COVID with the restrictions on us being active. But can I ask you about the science in the reverse? Have we got trials in animals or humans which shows us the effect of different types of activity volumes and the benefits? Is the reverse evidence-based and proven towards establishing guidelines on this?
With regard to chronic inflammation and with regard to the benefits of exercise, it seems that more is better. So there is a very clear dose-dependent relationship until a certain point. If people want to count steps, then 10,000 steps is actually spot on. But if you go from 2,000 to 4,000 steps, your mortality risk is halved, and if you go from 4,000 to 8,000, again you reduce your mortality risk by 50%. Yeah. So there is a dose-dependent relationship in just doing something. I'm not talking about sport. I'm talking about simply not being physically inactive.
Yeah. And though if we link the two studies, your comments to Bob, we heard Bob's study analysed against the global guidelines, the guidelines many countries have, which is the 150 minutes. So that volume was shown to have the association we heard from Bob. But do you know anything about more about that you can share? Is it intensity? Does it have to be more intense or less intense? What do we know more about that dose response?
We know that even moderate exercise has a lot of beneficial effects. It's claimed that it decreases the risk of maybe 35 different diseases. And we also know that moderate exercise can be used as a treatment in patients with cancer, in type 2 diabetes, in cardiovascular diseases. But if a person is able to increase heart rate, then to exercise with some intensity, then the effect of exercise is enhanced.
Okay, so Bente, we're all about looking at what more research we need, and you're sharing with us the knowledge from your lab and globally. Can you give us a sense of or identify what you'd contribute to that list of 5 from your side? What do we need to know more about that is a research gap that might be either prohibiting action that we want to see, or indeed would improve and enhance our actions? I'm going to come back to Bob on that question as well.
When we look at the epidemiology, it's clear that regular physical activity has a lot of effects. What we need to understand the big black box. Why is it so efficient? We need to know what is happening within the cells, which signaling pathways are exercise activating. We need to know that in order to better be able to prescribe exercise as medicine for specific diseases.
Thank you. And I've made a note of those. I hope others are as well. Bob, would you like to come back and join us and tell me what you might say is one of your next research priorities?
Well, I think it would be very interesting to look specifically at the dosing, as you've sort of alluded to. If we did more intense exercise, would that have more of an effect? And I'm suspicious as patients age, perhaps they may need less to get some of this same benefit. And certainly we know in study after study, the biggest bang for the buck is getting somebody who's doing nothing to doing just little bits of activity. Really meeting the physical activity guidelines gives you the bulk of the benefits that you see. And when you go above and beyond the physical activity guidelines, there's more benefit, but that curve starts to flatten. We see less benefit with the time spent. As you get beyond 150 minutes a week, each added minute brings less benefit than when you're just in, less than 30 or 40 minutes a week.
Thank you, Bob. So you've pointed to a couple of issues we'll pick up in our second part of this webinar, where we're talking about the implications. And you mentioned how important this could be for older adults, and we know they're more vulnerable. And you mentioned least active and how the gain is going to be so big with those who could benefit from just doing more at a very modest level of this moderate and light intensity activity. Bente mentioned the mechanisms, the black box. You'd like more research is needed to understand those multiple pathways. We've spoken about the inflammation, but we'll come back when we discuss those 5 questions we want, because I'd like to introduce the third panelist for this first section, particularly, and I'm very pleased to introduce Professor Pedro Halal from the Federal University of Pilates in Brazil. Welcome to you, Pedro, epidemiologist, scientist, editor-in-chief of the Journal of Physical Activity and Health. You took a break from your research to just be dean of the university for 4 years, and you've returned now. And we've invited you in particular because you are leading one of the largest epidemiological studies on COVID in Brazil, a country that's still got high levels of COVID. The context there we read and hear daily on the news. The study, I think, is called EpiCovid, and I would be delighted if you would share with us, what are you doing? What's the study about? And how, as a physical activity researcher, this is complementary or indeed directly relevant. Welcome, Pedro.
Hi, Fiona. Hi, everyone. It's my pleasure to be here. So first of all, as a Brazilian, I need to say a little bit about COVID in Brazil. So we only represent 2.7% of the world's population, but unfortunately, we represent almost 13% of the global COVID-19 deaths. So there is this 4.5-fold difference between what would be expected given the size of our country and what we are actually seeing. And, there are lots of reasons why Brazil has been hit so hard by COVID-19, and we can expand on those, but realistically, it's an anti-science posture or approach from the federal government that leads us to this terrible situation. But let me tell you a little bit about the EpiCovid study. So this is a series of cross-sectional studies on COVID-19 in Brazil. So in each round of the study, and we have conducted 5 already, in each round of the study, we visit 133 cities spread all over the country, and we test and interview 33,000 people. And we go and do COVID testing, and we go do questionnaire, and in that questionnaire, we obviously ask questions about physical activity. So first, in terms of the key results of this study, one of the key ones was the triple inequality concept. So we found marked regional, socioeconomic, and ethnic inequality in COVID infections in Brazil. The North region much more affected than the other regions. Black people and indigenous population much more affected than the white population. And finally, the poorest populations more affected than the richest population, portions of the population. And that inequality was striking. In terms of physical activity, what we found in the EpiCovid project was that physical activity levels declined considerably as compared to previous levels detected in our surveillance systems. So it is a way, Fiona, in which I can use my 2 hats. So my hat as the traditional epidemiologist doing epidemiological study on a new disease that everyone wants to hear about, and the physical activity hat on a risk factor that is strongly connected to COVID-19, as explained by Bob and Bente. So this is pretty much what I'm doing at this stage.
Yeah, Pedro, fascinating and a major initiative, and remarkable and important that it's being funded and carrying on and supported. And we'll come back to that need for more research and getting that financial support in a moment. I'm seeing some questions about the measures that are used in these types of studies. Both Bob, your study, you might answer that online, and your paper has got details. And Pedro, you're mentioning that you're monitoring, and you just said you're seeing a very large decline in physical activity levels. Now, worldwide, everyone's asking, has physical activity gone up or gone down? And globally, we don't have a single answer there. This, do you have national data from your ongoing surveillance system in Brazil now, or can you tell us about that? Is it carrying on?
Yes, Fiona. So there are two parts of this question. So the first one is that we had a surveillance system going on in Brazil, and unfortunately, it is not happening now because of the pandemic. So we don't have data from the surveillance system. But our group is doing our own national study using pretty much the same instruments as they used in the surveillance system. And we can show that the reduction was large. It's almost half the proportion of the population meeting physical activity guidelines during the pandemic. So I don't know whether this will be exactly the same in other countries, but at least in Brazil, we know that levels declined a lot. And we know that the surveillance system has not been continued during the pandemic, which is a shame.
Yeah, major public issue there. If we're not continuing our surveillance systems, we won't have answers to these important questions. I'm sure other panelists will pick up on that. Let me ask one last question from Catalina from the Q&A of our audience, because they're raising the question, she's raising the question about people being fearful about returning to physical activity because of complications. I suspect some of that is about the safety of it, but also there's the personal health. And it's reminded me to explore with you, Pedro, is your work focusing on also identifying long COVID? And can you speak to research on long COVID, as that's going to be an issue? What's your experience and knowledge so far in Brazil?
This is extremely interesting. Thanks for the question. So we just ran the last round of the EpiCovid study. And the one finding that impressed me a lot was that 47% of the COVID cases reported to have long-lasting symptoms. And I mean, over 2 months after this first symptom, they were still feeling something, or at least 1 or 2 symptoms. So this brings a whole issue of long COVID. And we know that a challenge ahead is that physical activity is important in the prevention of severe COVID cases, as shown by Bob and Bente, but physical activity will also be important for those who already have been infected and need to get back to normal life. So there is a treatment approach to it in addition to the preventative approach. And I think that is one of the key research questions. And I'm already replying to your question. One of the key research questions is, what is the role of physical activity in the treatment of long COVID?
Well, thank you. So I can jump asking you, because I heard that question. Thank you very much. And I want to extend that question to the audience, because if you're doing research on long COVID, if you're doing similar epi studies or other studies related to physical activity in COVID, tell us about it in the chat box and your questions to the panelists in the Q&A. I'm going to pause my questions and hand back to our moderator, Amanda, to take us forward into the discussion on what we should be doing with this evidence. Amanda, thank you.
Thanks a lot, Fiona, and a great setup, because we now really do have a sense of what is actually going on in the science and in a range of areas of the science right now. I've been trying as well to monitor a little bit the Q&A, and I've been picking up a lot of questions which are also about the so what, the frustration behind of, as researchers, we know that physical activity is important, and why is this not really being taken into consideration? Why aren't governments, policy, public health, why are these implications not really being integrated into responses. To help answer some of those questions, we haven't yet heard from Dr. Jim Salas, but Jim is with us. He's a distinguished professor emeritus in Herbert Weinheim School of Public Health at the University of California, San Diego, as well as a professorial fellow at the Australian Catholic University in Melbourne. Jim, good to have you with us. It's also early morning for you. Past president of the Society of Behavioral Medicine. And I think that's a really important part of the story that we're going to hear from you today as well, that behavioral medicine part to it. And also, I think your real passion as well as your rigor in trying to understand this idea about promoting physical activity and what that means in terms of policy, environmental influences, nutrition, and obesity. So really, to sort of get us going, Jim, it's really, as I've said in the Q&A, we've seen it, it's that why question. Why do policymakers and practitioners, what do they need to be doing more on in terms of physical activity? Given the latest research, we've seen the latest research over the last 45 minutes. So why do we need to be doing more? And then, of course, what does that actually look like? Over to you, Jim.
Well, I think first, it's a pleasure to be here, and thank you so much to Fiona and team for putting on this important webinar that I hope is seen by very many people. So we've seen a lot about why. Why should we do more? Why should we care about physical activity during the pandemic? And to all the reasons we've heard, helping with the chronic diseases that increase risk, improving immunity and inflammation. I would like to add another benefit that's not directly related to COVID outcomes necessarily, but which is stress, because basically the pandemic is putting everybody in the world basically under stress. And we've known for decades that physical activity is one of the best preventive measures that you can take, and one of the best treatments for anxiety and depression as well, in youth as well as adults. So even if activity didn't improve COVID outcomes, it would still improve quality of life for people during the pandemic. So what should we be doing about it? I would say, first, let's stop keeping physical activity a secret. In the United States, for sure, there has been really little or no effort to educate people and tell them physical activity will help you during the pandemic. And that's why we're so pleased that Bob Salas's paper has gotten a lot of public attention. So it's an alert to the population to think about being active, work harder at being active. And I would say, we should be helping people find ways that they can be active during the pandemic in ways that they enjoy as much as possible, and not make physical activity an obligation that's drudgery or not pleasant. Because I will tell you from my point of view, and probably everybody else on the panel, especially during the lockdowns when we were cut off from people and our movements were limited, the physical activity I did every day, going out for a walk or a bike ride, was the highlight of my day. So really, we should think about this as a quality of life intervention as well.
Well, Jim, I'm just gonna jump in on this. So you talked about some of those whys. Would you say that there's some sort of difference then in terms of lower middle income countries and for other countries, particularly given the COVID context, where physical activity really needs to be promoted even more?
Well, I would say, from my point of view, it's relevant in all countries. Everybody is going to benefit from being active. And there's no country, I would say, where we would be pleased with the percent of the population who is active. there's a need to increase physical activity in every country. And we are not making improvements. WHO has been doing enough surveillance over time to know that very few countries are increasing. Some countries are decreasing, but overall, we're not making progress.
So what do we need to do to make it easier? As you said, we can promote, but to actually make it easier, and particularly to make it easier for those who find it the most difficult for lots of very good reasons to actually partake in physical activity. And again, it sounds to me that COVID has amplified that more difficult for some, even though it existed beforehand.
Right. Well, yes, we should pay attention to our responses to COVID that included closing down most of the places where people did activity. It turns out that you have to be active in a place, and some places are better than others. So yes, you can do physical activity along with exercise videos on YouTube or whatever. And when you're locked up in your house, that's probably that may be the best option, but it may not be the most enjoyable. You know, how can we get people active? Well, I would certainly emphasize the WHO's GAPA initiative, the Global Action Plan for Physical Activity. And one of the aspects of that I think is most important of the 4 overall strategies is to make sure there are active places, that there are easy to access places for physical activity that everybody can use. And I would think of 2 major categories. One is ability to walk and bike for transportation, so you can get to where you need to go without necessarily getting into a car or even public transit. So having sidewalks and footpaths, having safe places to bicycle are very important. And we've seen movement during the pandemic of improving some of these places. The other aspect is places for people to go for recreation. So that would include parks, that would include trails. And we can think about everybody needs access to those places, and we need to think about the design. So there are places in parks for children to be active on a playground. There are walking paths, so adults can take a stroll. Or there's workout equipment in the park. And many places of the world, I've seen just many people taking advantage. So we have to think about, instead of making it harder for people to be active by taking away places, we need to be making it easier by by making better places to be active, and then encouraging people to use those.
So I mean, what I'm taking away, Jim, on this is a definite call to action to cities from around the world to be really changing the environment for physical activity. Am I right on that?
Yes, definitely! Exclamation point.
Definitely, I love that. I mean, there's clearly a city's part. There's a national government's side of it. So again, what do national governments, if you're talking about real policy change, practice change, but what does policy need to be really looking like and shifting, given the research that we've heard? Again, this is directly linked to the research that we've heard from Bob, from Pedro, and from Bente.
Well, I would start by during the pandemic. One of the policies I would like to see is increased measurement of physical activity, as maybe along the lines of the study that Pedro was just talking about, but also inclusion of physical activity into the modeling that's done that informs national policy about pandemic response in many countries. So, again, the modeling that guided how can we reduce transmission included closing down parks and trails and that sort of thing. But that modeling did not include the potential harms of those actions in reducing physical activity, which we just seen results in higher susceptibility to severe COVID outcomes. So I think I would like to see right now and going forward in future infectious disease outbreaks, inclusion of physical activity in the modeling, so that the benefits of physical activity can be incorporated into pandemic responses. But we're talking about more policies that affect physical activity. Transportation policy affects physical activity. If in the U.S., transportation policy is mainly about moving cars and it pays very little attention to walking and biking, we would like to see those policies changed, and we're working towards changing those. Where Bente lives in Denmark, of course, walking and biking is really emphasized as a goal of transportation. So we would like to see more countries do that. And then we would like to see policies to make sure there are parks everywhere, in every neighborhood, trails linking communities together, that sort of thing. And that can be a combination of national and local policy.
Jim, thanks a lot. I'm going to pull in Bob, because I think I'm really interested to sort of get Bob's view as well. Then I'm going to turn to Pedro straight afterwards. But Bob, you're an actual practitioner. You talked to us already about, putting in place since 2009, the sort of physical activity as a vital sign. So this has already existed. I'm going back to some of our questions of why aren't we doing more of this? How did that go down with your peers, with your fellow medical practitioners? Because it's trying to get underneath of how can we actually really get these changes in place, given that the research is out there and it's getting better and better, and COVID has allowed us to actually get that even more robust.
Yeah, so our exercise vital sign is actually asked by the medical assistant as they're rooming the patient. They measure their blood pressure, their pulse, their temperature, they weigh them, they ask them about smoking. There are 2 questions about physical activity. And we simply ask of our physicians just a comment, either good job, I see you're exercising, keep it up, or today I noticed that your blood pressure is elevated or your blood sugar is elevated. Before I put you on a medication for that, I would like you to try to walk 30 minutes a day. That's all we're asking, just a 1 sentence from our physicians. And I tell you, it was very easy to establish the exercise vital sign in our system. It's spread to all of our Kaiser regions. We have about 12 million patients in our system, and every patient who comes into a Kaiser outpatient facility gets asked about their exercise habits. Now, the uptake, like anything, it's not always focused on. And if you've got a lot of other things to do in that visit, you're not going to spend an inordinate amount of time talking about physical activity, but certainly it increases the awareness, and it's a starting point to begin a discussion that we really encourage our physicians and other providers to talk about it in the midst of whatever disease they're treating, and including it in their treatment plan.
But so given that your medical assistants don't have that much time possibly to ask those questions, are they using, or are you also using any innovative ways of actually being able to promote that? There's a lot of tech out there today, again, to this idea of how can we scale this up? How can this become, mainstream standard practice, as opposed to what you're doing in one particular region and nobody else in the world is doing it?
Yeah, certainly I'm not deluded that the medical establishment is going to change physical activity levels across the country. We saw that with smoking. But it took a while before physicians actually started to ask patients, do you smoke? And of course, at the beginning, we all said, we're too busy to ask about smoking. I've got too many other things to do. I can't be bothered with that. But, now it's established that we ask every patient about their smoking habits, and we at least offer them some interventions that may help them with their smoking. And we're just looking for the same things the same sort of treatment of exercise. But I really think the solution is going to come, as Jim has outlined, that it's in the community. When we, it wasn't physicians asking about smoking that lowered smoking rates. It was really had more to do with, a stigma that was assigned to smoking, that smoking wasn't cool, that it wasn't something you would want to brag about. And I think we need to treat physical inactivity in the same way. And, another point that I'd like to make in our data that I think is missed is I was astounded by the effect of race on COVID, that there really was no effect. And I think in the United States, we have scared ethnic minority communities that you are such a higher risk to die from COVID. But when you control for their physical activity levels and their chronic diseases, race had absolutely no effect. And the other studies that have been done have shown this really. And so I think the messaging is for those communities, you need to be active, you need to be healthy. It's not about your race, it's about your chronic disease burden and your physical activity level, things like that. That's really what drives the risk for COVID. And I haven't heard that message put forth. And I think we've scared these minority communities that I'm just giving up hope because of my race. I can't change that, but you can change the risk factors that often go along with that to lower your risk.
Thanks, Dr. Bob. Pedro, I know that you've been impatient, but you've been waiting very patiently to come in, I think, as well, to be able to comment on some of the interventions from Jim and the sort of policy changes, as well as the environmental changes that he was talking about. Go ahead, Pedro.
No, it's just a quick comment about the transportation issue that Jim brought, and which is extremely important. But the one problem I see with transportation policies towards more active transportation modes is that here in Brazil and in several other low and middle income countries, having a car is like an object of desire. So you use your bicycle or you walk to work because you have no other options. So as soon as your family gets wealthier, what you want to do is to buy a car. And we need to advocate, oh, no, it's even better for your health if you continue to walk or cycle to work. So there is this difference across countries that we need to think about, because the type of intervention to promote active transportation in low and middle income countries is somehow different to the type of intervention we need in high income countries. That's just a quick comment.
No, Pedro, thank you. And really important that we really are aware of knowing that we have research that is showing the importance of promoting physical activity, but understanding that applying those messages is going to change from context to context, from country to country, and particularly you're talking about differences in terms of lower middle income countries and the global north, which is not looking at the same incentives or motivations to actually do physical activity. One of the things I'd just like to keep you with me though, because sort of moving to the next part of those sort of implications, I know that you mentioned it briefly, you've been collaborating with the national government on the on new national guidelines. And we've been talking about WHO's global guidelines and actually now talking in Brazil about actually translating those into national guidelines. Have you been able to actually continue to do that through the pandemic? Has it got going? Is there a future in that? And that's particularly interesting because I think many countries are looking to actually applying their guidelines.
Yes, Amanda, thanks for asking. This is interesting. So Brazil has never done its own guidelines. And a couple of years ago, I was invited to lead a group to produce those guidelines. And we worked very hard for kind of a year. And then we even had a meeting with Fiona to present the draft of the guidelines. And, they are about to be launched or to be released very soon. They are ready for something like 6 months now. But, because of the pandemic and these things, the guidelines have not been launched yet, but they will soon be launched. And Brazil will have, for the first time ever, its national physical activity guideline, which is actually good because, we want more countries to have their own guidelines and to think about physical activity and policy for physical activity promotion.
Thanks, Dr. Pedro. I'm just sort of done a quick look at some of the questions that we've got in the Q&A, and I just thought as well, bringing Jim back in just for a moment, Jim. One of the questions that's come up is as well, for decision makers, other key actors, stakeholders, what do they need to prioritize physical activity in terms of environmental facilities currently through the pandemic, but also in that recovery and post-pandemic phase? Where should they really be going? Because if they've not been doing it so far, we've talked a little bit about what some cities are doing, but again, how in terms of when they're weighing things up, how are they meant to be prioritizing physical activity in their environmental facilities?
Well, I guess I would say that for these decision makers need a push. And where are they going to get that push? That they, in most countries, they have apparently not gotten yet. I would like to see more priority given to physical activity in the medical field, in the public health field. It seems like so many, we have so many health benefits from physical activity that these should be higher priorities in medicine and public health. And I can tell you, physical activity is not a priority. When you look at the capacity, when you look at the funding, when you look at the staffing, when you look at promotional campaigns, it's just not a priority. The evidence is very strong. The response and action to that evidence is very weak in most places around the world. The other source of push to policymakers really needs to come from the people. There are many people who are active, who understand the importance of it, who find that it's an important part of their day and their lifestyle and their enjoyment. But there's no organized way for them to have input in and say that we need to change our policies. We need to, as nations, we need to work on getting people active. So I really think of citizen advocacy as an important strategy. And we and colleagues of mine have been working on this for a while. And I will say, when you help people understand that they can have input into their policymakers at a local or national level, they love that. They feel empowered. They feel stronger. And we've seen this from adolescents to older adults. And it can be done, but it just needs to be done much, much more.
Thanks, Jim. And also a really strong message coming from, from a research community talking about citizens' action. And it's a really interesting, again, I talked a little bit about those interfaces at the beginning, that sort of that science to people, science to citizen interface is also really important. On the sort of back of that, I'd also like to bring Bente. Would you come back and join us, Bente? Because not only are you clearly a top researcher, but you're also a communicator. You're also as well engaging more publicly. So it'd be really useful to hear from you as well. If we're taking the science and looking at those policy implications or people implications, how can we take that one step further?
No, I think it's so obvious, as we just heard, that we walk more if we live near green parks and green spaces, and if the parks are illuminated when it is dark. So what I hope for is that, just as politicians always should consider gender and ethnic issues, they should also consider health aspects, including how infrastructure and architecture may influence the population's physical activity level. We still, even in Denmark, where we have a lot of focus on physical activity, we build new cities where no one wants to walk, or where it's difficult to use a bicycle. So I really think it should be a law saying that you are not allowed to create infrastructure and architecture that does not support people's physical activity, life.
Thanks a lot, Bente. Really clear, and again, this really important message of actually bringing the evidence into the public space with some very clear messages. I think, well, two things. First of all, I just want to draw everybody's attention to the chat. There's some great links being put into the chat, a lot of different tools, links into research papers. So just so that everybody's aware, to take a look at the chat. And then I'm also going to turn back to Fiona, because it's about time that we actually turn back into what is the research, what more research do we need to be talking about? I know, Fiona, you've been noting everything as we've been going through, as we've been doing our double act of moderation today. I'm going to hand back to you, Fiona, to continue to interrogate our panelists on where do we need to go next with the research.
Thank you, Amanda, and thank you, panelists, for this really important and inspiring discussion about what we can do with the evidence. So just turning back to where we started, I posed the question about trying to identify the top 5 research priorities that we're facing and inviting the audience to contribute their thoughts. We've heard some of those from you already, and I'm sure you've been thinking, Bente, you want more research to really understand that black box, the pathways, the signaling, the metabolic level changes, to better understand that and answer key questions. I also heard about understanding more of the dose, how much, to improve our knowledge of what is an overarching evidence base of value of all levels of physical activity. But let me see, and I'd invite the panelists to join the table here and see whether it's more of that level of the clinical. Is it more on the practice, Bob, about how we advise and counsel, the tools we can use in the health system? But then, of course, Jim, you've mentioned outside in the community and your background in researching that area. So what I'm going to go around the table and ask you to add more to that list and invite you to keep looking at the Q&A and the chat box. So we're going to multitask, and I'm going to go back to Bente for any addition that you were thinking of. I'll loop back again if you want to pass on this one. But Bente, you want to expand on that at all, or are you're sitting on that black box research priority?
We have to distinguish between exercise as prophylaxis and exercise as treatment. Exercise as prophylaxis, just go and do something. Exercise as treatment of cancer, or exercise as key treatment of COVID long. I think we need to understand exactly which signaling pathways we want to activate.
Thank you. Now let me go to Bob. Mentioning research there on long COVID, are you doing some? What would be your call for the next projects we must globally focus on? Bob?
Yeah, I think that the effective exercise on long COVID is very important. I've seen no treatment that, in my mind, does better than having patients engage in regular exercise. I'd really like to see some studies that could really clearly prove a dose-response relationship for long COVID and exercise.
Yeah, thank you, Bob. And I wonder whether there's anyone in our audience who's working in clinics and practices providing care for long COVID patients. I'm aware UCL and others in the UK have started some controlled trials of long COVID. Jim, what's on your top list, please, Jim?
Well, I have several, but I'm going to bring up a topic that we haven't talked about, and that is the benefit of physical activity for boosting the effectiveness of vaccinations. That has been shown, in quite a few studies, especially in older adults whose immune systems are weakened. And it really hasn't been a major issue yet, because the vaccines for COVID have been so amazingly effective. So they really haven't, you can't boost much more than 95% effectiveness. But there's a coming question, and that is, we don't know how long the vaccination effectiveness is going to last. And given the demonstrated immune effects of physical activity, I would like to see studies on physical activity effects on improving sustainability of vaccination effects.
Thank you, Jim. You're absolutely right. Very important to raise, and I'm pleased you did so. And someone from our Q&A is asking about the relationship between physical activity and risks of infection. So this clinical area, this impact both as Bente, prophylaxis, as treatment, and then Jim as part of enhancing the impact of the vaccination. Pedro, what's on your list? over and above perhaps that long COVID research?
Yeah, and probably you already knew what I would say. So my priority would be to study how to scale up physical activity interventions in long COVID-19 clinics and health facilities. I think it's a matter of scaling up and a matter of implementation, because the science and the biological plausibility is here. So we just need to make it happen in real world. And in order to do that, we need to have research on implementation and scaling up.
Thank you, Pedro. I'm sure some in the audience will be thinking about whether if we're scaling up, it means we already have the amount and the approach for these long COVID patients, the regime, if you will. Bob and Bente, do we have an answer now for what should clinics who are dealing with the many long COVID patients around the world, what is the recommendations that we are having at the moment? Bob first, Bente next.
Well, I have not seen any clear guidelines, but in my mind, I'm going to start with the physical activity guidelines. I think aiming for that makes the most sense. So let's just start there, or even a portion of that. We know, again, that that curve is very steep. Of just getting a few minutes has real benefit, and going beyond 150, they start to lessen. I got to believe it's going to be the same with long COVID, but I think that's really where we need good evidence to be able to counsel patients.
Yeah, with very severe patients or severely affected long COVID patients, it might be how to increase, how much, not the goal, which I think we might all agree with you. So I think we have a guiding path, but I'm sure some clinicians, practitioners, physios, those in clinics. Bente, what can we learn from and use now while we do research and evaluate those treatment and rehabilitation programs? Bente.
Difficult question. I think it's all about breaking the sedentary lifestyle, or breaking inactivity to just do something. I know that there are voices out there saying that the patients would not, that it's dangerous for them to do more intense exercise. I haven't seen the evidence behind that. So I think we need randomized controlled trials to see how feasibility studies to see how much can we get along with.
Let me give Pedro the floor to if he wants to respond. You were about scaling up, and Bente is now calling for an RCT. If I was a politician wondering at a national government, am I scaling up something I know, or am I doing an RCT to find it?
Yeah, this is a difficult question, but in my view, the RCT will provide an answer on the exact dose or the exact something, but realistically, we already know and we already have evidence that physical activity will benefit long COVID patients. So I would go for the scale up regardless, but obviously the scaling up can be modified as soon as we have RCT results to adjust for the dosing or things like that. But I would not put in hold the scaling up, because we already know that physical activity will benefit these patients.
Exactly, and with a public health problem the size of this global pandemic, we can't wait, and so we actually need the resourcing. Jim, you were talking about mobilizing the resourcing. You are unsatisfied by the way you presented that. Evidence is strong, action is weak. We've got to mobilize the resources for the research and the implementation at the same time. So round the table again, we've been doing this for a long time. Is now the time? Is there a moment we can mobilize those resources, and where from? So Jim, back to you. You have been successful in the US. Are you optimistic? And what guidance can you offer to us and the audience around the world to mobilize the research funding as well as the implementation? But let's stick on research. Jim.
Well, I think this is a very opportune moment to improve, enhance the priority of physical activity in public health and medicine. I think, again, the evidence is just overwhelming about the health benefits, but it's been a background issue in public health and medicine that has really not been focused on. I think the evidence that physical activity is one of the most effective things that you might be able to do to prevent hospitalization and death from an infectious disease is a headline for most people. The infectious disease people, I would assume, have never thought about physical activity in any way.
So a new opportunity opening up with this.
Exactly. And we need to jump on this as advocates and say, all right, let's don't just sit on this evidence, let's act on it.
Very good signal. Thank you. Sorry for talking over you there, Jim, just in the interest of time. And I want to acknowledge a question or suggestions from Ian on the Q&A, raising the issue of not only incentivizing engagement and implementation of or being active. So that's another area of research. But then also Ian has raised the question of research on the cost of inaction, the cost to healthcare. Bob, you're an obvious one for me to come back to. Kaiser, do we know enough? We've got some numbers, 54 billion a year from 2016, and that's only the direct costs. Do we need to prioritize the economic assessment of physical activity and to have those arguments? Bob?
Well, certainly, and we have evidence in our Kaiser Permanente system that patients whose exercise vital sign is consistently low cost us much more, that they're seen more frequently, they require more medications, more lab testing, they're admitted more frequently. So we have found that certainly in our data. And I wanted to kind of go back to the discussion on long COVID and just add in the importance of watching for cardiac symptoms. I think that is the one risk. We certainly know that COVID can infect the heart and potentially could lead to an arrhythmia and things like that. But I think that's been overestimated. More recent studies have shown it's very short-lived. But I always add that caveat to patients to watch for symptoms like palpitations, chest pain, excessive shortness of breath as they start to return to exercise. That's very important as well.
Yeah,
so
thank you,
I think
Bob.
that should be emphasized.
We've got the clock running on us, and I'm going to hand back to Amanda after one last question, because I want to turn to Pedro. You're there in Brazil, a country that has actually done an astonishing increase in capacity for research and research output. We've seen that. Neighboring countries are doing well as well, but globally we know there's an imbalance between the research activity, the research funding. Can you tell us from your perspective, Pedro, your ask and your suggestions of what is needed to mobilize those research funds, build capacity in countries like Brazil and elsewhere in low and middle income countries particularly? Pedro.
Yes, Fiona, you know, Brazil is now experiencing a very odd situation that I hope will not last long. So talking about Brazil specifically, it's very difficult. But the one thing I learned from low and middle income countries is that funding is equivalent to the government perception on the importance of the subject. So definitely we need to get low and middle income country governments to be engaged with physical activity so that there will be funding for it, because otherwise we do not have enough funding agencies that are independent from the government. So if we don't engage the government, it's very difficult to get funding. This would be my one comment about it. And obviously the situation in Brazil is not easy at this stage. So Brazil would not be the best example as it was in the near past. You all remember we had a time where Brazil was scaling up interventions, publishing a lot, doing science, doing policy, doing surveillance, and the situation is no longer the same, unfortunately.
But, you know, within your answer, very important points. And of course, as you mentioned, that history, that North-South, and I think now South-South collaborations need to be reflected. And Jim, I would have thought there's an opportunity as that is recognized now. We've got to transfer knowledge and build capacity between and within North-North, North-South, and South-South. So thank you. I hand back to Amanda because the clock is running down. Amanda.
Thank you very much, Fiona. I just thought it would be, I thought it'd be quite useful actually to actually bring Jim in just to be able to respond to that, because you've been so involved in the North-North, but also the North-South capacity question. We've talked a lot about what do we need to research, what the implications are of the current research. We've talked a lot about where the investment needs to be. We've just touched on the question of capacity. You can't do research, and I've been working in the research area as well for years, unless we actually have the people, and particularly young people, in the right place, the right parts of the world to be able to do that. So, Jim, what can we put in place? What should we be shifting, changing to actually really improve that capacity globally?
Let's start with the present moment, with the people that we have on this webinar. I would like to appoint every person on this webinar to advocate to their health ministries that we need to do more research on physical activity in every country. Research and programming and interventions and policy change. Somebody needs to be that spark if it's not already happening in that country. And, we've had some just wonderful success in creating physical activity research networks across countries and collaborating. And really that has generated so much capacity and brought new people into the field and created more prominence and elevated the prominence of physical activity in these countries. I think that takes leadership, and it takes funding, and sometimes that funding, very rarely, that funding comes from any kind of international body. And so more often it's come from little bits of funding within the country, and you combine those small efforts into a network that's working together, and you get something big that then when you bring the results back has another impact in that country. But somebody has to fund it, and frankly that is the Achilles heel of physical activity. We have trouble generating that funding and generating the commitment to make that funding.
Jim, thanks so much. And again, really important, first of all, a call to action for everybody sitting around this particular table. I would say us here on the webinar, on the panel, but also all the participants as well, a call to action to them to be able to go to their ministries, go to their research centers, go and actually work in those networks with civil society. And I see this in the chat as well, a lot around making the connections, creating those networks despite the funding challenge. And those connections seem to be coming out globally as a really sort of a red thread that we have had running through the whole conversation. At this point, because yes, the clock is definitely running down, I'm going to hand back to Fiona to try her best to wrap up. I warned everybody that this was going to be a content-rich webinar today. It certainly has been. I've never been with a group of panelists who have all been shaking their heads while the others have been speaking so much. So incredibly engaged, but also really there. So I know that the participants haven't always seen those shaken heads. You should know there was a lot of conversation going around our table as well. Fiona, over to you to actually just wrap us up and take us to the end over the next 3 or 4 minutes.
Yes, and that's going to be a challenge, but let me start by thanking the panelists for what has been an incredible last 85 minutes, and your time is greatly appreciated, your expertise and your contributions. So I'll try and summarize the last 85 minutes before giving a preview of next week's reINVENT series number 4. Summary remarks. We started off with the science, and we heard about the existing evidence, and we had shared with us from Bob new evidence about the double duty role of physical activity, not only it directly affecting and improving individuals' health and prevention of those severe COVID outcomes, but also that it actually is, of course, critical to those underlying conditions that we hear of and can reduce and prevent those. We moved to hear from Bente about the metabolic pathways. And really the summary I heard really was that physical activity has a strong evidence base that it can reduce the inflammation pathway and therefore improve our health outcomes. More research needed, but a strong evidence there. We went from the science and it being strong to the action that is weak. And we learned from Jim that we should all become citizen advocates. So from the bottom up, we all need to take on responsibility to call on communities and politicians, leaders, decision makers across all sectors to act. But of course, as many of us in our professionals, we need to act as well, act on this strong evidence. I'll return to that. So bottom up, top down, systems approach, horizontal and vertical. Jim really gave us some clear messages. Tell people and then work on the active places. We have to provide the places where people can be active safely during COVID and going on from this, because we know it's the environments that matter. Ability to walk and cycle safely for everyone. The places to recreate, whether they're parks or sports fields. These need to be maintained. They need to be accessible and affordable for all. We also heard from Bob about the need to embed physical activity in primary healthcare. There's a need for us to return and strengthen that fundamentals, that advice from health professionals is an important contribution to promoting physical activity, but must be supported, insufficient on its own. And that's where the priorities of physical activity within the public health action must be raised. And Jim, you spoke to this very clearly, that we have got to raise, and it's the perceptions that need to be influenced. So all of us have to take on this advocacy role, and Pedro spoke how critical it is. So with a lot of clarity about the science, a lot of clarity about what we need to do, there were research questions, and the research questions were numerous, more than 5, and of course I'm very pleased about those. I won't summarize now, but we will capture them in the recording of this, and of course we're listening to them, but they spanned from the black box mechanisms all the way through to rehabilitation of long COVID and everything in between. Learning while doing, and we've got to mobilize more research funds and resources and build the capacity. A rich seminar and webinar for the reINVENT series. Next week, we have the 4th of our series, where we turn the spotlight to the hidden sector, the vast and deep role that civil society actors play in providing the sport, physical activity, walking, cycling opportunities for children, for adults, for people with disabilities, for health and for social outcomes. Each one of our webinars is open to all. Join us next week, register now, and of course, stay in contact, because the long recording, 90 minutes, and short 4-minute highlight videos will be coming available. I finish again by thanking the panelists, the audience, the technicians, and the teams in the pilots managing this webinar, and wish you all a very good day. See you next week. Thank you.